Welcome to SARC Talk. SARC is a nonprofit cancer research organization that develops and manages clinical research trials in pediatric and adult sarcomas. SARC Talk is a podcast to discuss activities of SARC, interview sarcoma research leaders, and review scientific initiatives in the sarcoma field.
Welcome to SARC Talk, episode 15. My name is Scott Okuno, a medical oncologist at Mayo Clinic and Chief Medical Officer of SARC. All episodes are posted on our website, Spotify, or YouTube SARC channel, and wherever podcasts are available. Please subscribe and submit comments because we do look at them. It is my pleasure today to have two sarcoma medical experts to discuss advances in liposarcoma. Our first guest is Dr. Albiruni Razak, who is an associate professor at the University of Toronto and medical oncology lead for sarcoma at Princess Margaret. He did his oncology training in Ireland and England and did a fellowship at Princess Margaret in drug development in 2013, for which he is now on staff. Our second guest is Dr. Neeta Somaiah. She's an associate professor in the Department of Sarcoma Medical Oncology at MD Anderson. She did her oncology training at Fox Chase Cancer Center and has been at MD Anderson since her fellowship. Both our guests are experts in the field of sarcoma, and we look forward to discussing new advances in liposarcoma. Dr. Razak and Dr. Somaiah, welcome to SARC Talk. Some of our audience would like to get to know you a little bit more. So Dr. Razak, please share with our audience a little bit about yourself and what you do at Princess Margaret.
Sure. Thank you, Dr. Okuno. I'm, as you have alluded earlier on, I'm a medical oncologist transcending what we call the Toronto Sarcoma Program, which is really one program, two institutions. And there are really two hospitals next to each other. And those two hospitals will be Princess Margaret Cancer Center and Mount Sinai Hospital. I have two areas of interest. The first is sarcoma, obviously, and we see all types of sarcomas. And I'm also a core member of the Phase 1 early drug developmental team at Princess Margaret.
So yes, this is a Canadian system there. You have two major hospitals, and other than sarcoma, you do develop Phase 1. So we'll explore that a little bit more. Dr. Somaiah, please tell our audience a little bit about yourself and what you do at MD Anderson.
Yeah, well, I am a sarcoma medical oncologist, and we have our own sarcoma medical oncology department at the University of Texas MD Anderson in Houston. I definitely clinically see all sarcoma cases, but I do predominantly have liposarcoma and GIST patients because that is a clinical and research and translational focus of mine. In the department, I also serve as the deputy chair, and I also oversee the clinical trials of the sarcoma medical oncology, which has grown substantially over the past few years.
Both of you have major sarcoma practices and major oncology practices there. So we will explore that a little bit more as well. Both of you, as I said, come from big sarcoma centers. What separates you guys from other cancer centers? You know, you do have expertise in pathology, you have expertise in radiology, you have expertise in radiation oncology, imaging, etc. So just describe a little bit more for our teams here that are listening. What is the makeup of a sarcoma center? And let's start maybe with Albi at Princess Margaret. What does that makeup look like? And then we'll get to the Dr. Somaiah as well at MD Anderson. So Albi?
Yeah, so within our services at Princess Margaret and Mount Sinai, we have dedicated core services for sarcoma, and this includes things like pathology, imaging, core imaging members that are involved in musculoskeletal and GI or thoracic oncology, and the clinical part as well, where we conduct multidisciplinary clinics, to include surgery, medical oncology, radiation, and we're one of the groups that have got simultaneous palliative care clinic running together with us. So, in one consult, you can get a medonc and a palliative care physician together seeing a patient. Um, the provision of service in Canada is very different because we adapt a socialist healthcare system. When there is a diagnosis of sarcoma, there is only certain centers that can take care of sarcoma patients. For example, in Ontario, which has got a population of 15, 16 million, there are only 4 centers that sarcoma patients can go to. So there is the challenge that they have to travel because Canada is a vast country geographic-wise, but with 1/10 of the population of, say, the US. But in this way, the services are streamlined. We maintain volumes and expertise within these centers.
Dr. Razak, thank you. That's quite a unique thing because that's a little different than we have in the United States here. So, Dr. Somaiah, kind of how you've put together the Sarcoma Center down at MD Anderson.
Yeah. And as you alluded to, when it comes to any cancer, but especially rare cancers, we need a group, right? We need our pathologists, we need the radiologists, we have musculoskeletal, we have abdominal imaging that are quite integrated into our tumor board discussions, interventional radiology, and then definitely our surgical colleagues. So we have the Sarcoma Medical Oncology Department that houses the faculty, the AP, the advanced practitioners, nurse practitioners, and also all the research unit of sarcoma medical oncology, which is all the clinical trials that we're running in our department. And then we have the Sarcoma Center, under which the surgeons, the orthopedic doctors, the radiation oncologists, and then sarcoma medical oncology come, and that's where the clinics are run, and the nurses. So, when patients come in through our new patients to our access team, there is an algorithm which determines which team they would see first, and then who is then consulted accordingly, depending on the stage of the cancer and type. We do have 2 weekly sarcoma tumor boards that are very well attended because as you can imagine, these cases do need multidisciplinary input, and not always the same answer comes out for a similar case because there are a lot of nuances in the patient and disease characteristics that require a change. So we have that. We also have our own sarcoma medical oncology meeting every week to review both inpatients and challenging outpatients to discuss. So the group has grown over the years. When I started, we were 6 faculty members, and now we have 12. And similarly, the number of clinical trials have gone from 5 to, I think over 20 right now. So the team is growing. Like I think everywhere, there is a high need for expertise in sarcoma care. And I think the goal, like in all centers, including yours, is to try and get patients access in a timely manner, which, sometimes still remains a challenge.
That's the opportunity. And, for all of us, Dr. Somaiah and Dr. Razak, you both have the expertise, not only the access, but also the breadth. And part of this ties into what we're trying to do at SARC is to kind of highlight areas where you have that breadth, where patients can come in, get multidisciplinary access, not just with a tumor board, but this is a sarcoma tumor board that's very specific. And then have the expertise not only in the clinical care, but as you brought out, Dr. Somaiah, gone from 5 up to 20 plus research protocols, and that just gets more and more people excited here. So we're working in revamping the Sarcoma Center parts across the United States. We'd be happy to look and explore where we look at, and you've already done that nationally, of which 4 centers in Ontario you would need to have sarcoma done. But in the United States, we don't have that centralized control, so we have to kind of look at it. So today we like to spend a little bit of time doing a deeper dive into liposarcoma. Last year we had Mark Dixon who talked about dedifferentiated liposarcoma, the workup, the multidisciplinary approach, kind of the overall themes of how to approach somebody with dedifferentiated liposarcoma. But today we like to talk a little bit more specifically about the trials that are being undertaken and kind of where we need to be in liposarcoma in 2024 and beyond. There's a huge amount of stuff that both of you have published in this space, so that's why we're excited to have both of you there. And I'll be in, Neeta, you can ask each other questions as we go along. But the first one is there's been a lot of more basic science exploring the targets of liposarcoma. I know, Dr. Somaiah, you and your group have published on this, and maybe you can share a little bit of the highlights of what we have now found out a little bit more and how other groups are proceeding as well with some of the targets of liposarcoma that you found.
So yeah, thank you for that question. And again, when we first started out, or when I rather first started out exploring liposarcomas, one of the first things was to do a deeper genomic and transcriptomic analysis of matched, well-differentiated and dedifferentiated samples from the same patient to see what was really going on and what was different between the so-called low-grade well-diffs and the dedifferentiated liposarcoma. Surprisingly, or not surprisingly, I should say, there were very few shared somatic mutations between the well-diff and dediff. I recall around 8%. And none of them were consistent, across the samples. What was consistent is the copy number alterations, both amplifications and deletions. And this is across multiple publications. We know, of course, the 12q chromosome with the MDM2, CDK4. Those genes tend to be amplified, almost classic, the MDM2 amplification across these tumor types, and seems to be an early event both for the low-grade, well-differentiated liposarcoma and dedifferentiated liposarcoma. What was interesting from that finding was that between the matched samples, at least there's some shared somatic mutation. So there does seem to be some clonal evolution of the well-diff and dediff, but then there seems to be just acquiring more alterations. And I think what we found was the dedifferentiated liposarcomas do have more deletions than the well-diff matched cases. When we do targeted sequencing, which was another publication just looking at clinical grade NGS testing on samples, you find mutations, infrequently. It's mostly copy number alterations. So I think the targetable alterations that come to mind across all these tumors is still the MDM2 CDK4 amplifications. In select patients, because there is a lot of, we call dedifferentiated liposarcoma as one group, but there is a lot of variability even within that group, which we see in clinical trial responses as well. So I think there, within cases, there could be a difference in their immune microenvironment and how they respond to immunotherapy. Also, other alterations that we sometimes see, we've seen EGFR, NF2, some other mutations that may or may not be oncogenic drivers or just accompanying alterations. So more to come on that, but that's in a nutshell. And I think what we're exploring further is the epigenetics of these tumors and how they're changing. So more to come on that.
Well, we'll come back to a couple of these highlights. And, you did highlight that we have a lot of knowledge about the role of the MDM2. We also have a role of the CDK4/6. And we should probably explore what Dr. Razak did, because he did a proof of concept study exploring targeting MDM2 and CDK4/6. And maybe, Dr. Razak, can you share with our group kind of how you designed that trial based on the information that, Neeta and her team and other people have done, and kind of where the next steps, the result of that, proof of concept study, and where do you think we should go with that?
Yeah, sure. So, the study you alluded to was actually a combination of MDM2 inhibitor and a CDK4 inhibitor. The idea behind that is quite simple on paper, but harder to execute because, as Dr. Somaiah alluded, the hallmarks of genomic alteration in dediff liposarcoma is mainly driven by the CDK4 and MDM2 amplification. So the low-hanging fruit there is to actually try these two combinations. So there is preclinical data, both in vitro and in vivo, that shows that there is synergy when you use these two drugs together, which strengthens the idea of combining these two drugs as a good route to pursue in Dediff liposarcoma. However, preclinically, even before we use these drugs in combination in humans, we know there is the challenge of myelosuppression. So, both drugs on its own are very myelosuppressive, and how do you safely combine this in a dose that you can achieve your target inhibition? So when the study was done, there were multiple regimens. There's about 3 to 5 regimens that we looked at, but we carried forward with 3, and that there was a regimen that is considered tolerable. This is the 3-weekly regimen of the combination drug, with the MDM2 given once every 3 weeks, and the CDK4 inhibitor is given 2 weeks on, 1 week off. But the bottom line is, where we went with that particular trial was that we found a safe/tolerable dose, but the efficacy was somewhat disappointing. So the efficacy that we saw didn't produce that synergy that we expected. It is no more. In fact, one could argue it could even be less than the drugs used as monotherapy. So that particular combination has been halted, is not being carried forward. But, and there's a big but, our involvement in early therapeutics in MDM2 spans back quite a few years now. And, we have come to a point where we have MDM2 inhibitors that are monotherapy with very little activity, but a lot of toxicities in liposarcoma patients. But as you know, there are quite a few drugs now that are being pushed forward because, there is activity and they have tolerable toxicities. So this is what I call the new generation MDM2 inhibitors, if you like. They're much more potent. They have more clinical activity, at least as monotherapy, and perhaps the toxicity is also less. So the question is, if these compounds do get a place, if you like, in the treatment armamentarium for Dediff liposarcoma, do we have to revisit this? And how do we do it, right? Do we take this, do we do it in heavily pretreated people when their marrow reserves are poor, or actually we bring this forward and adequately support their marrow function? So there are avenues that we could pursue, but I think it will all also depend how viable is this next generations of MDM2 inhibitors in the clinical space as they're being assessed as monotherapy.
I can just see your mind clicking there. This is how a phase 1 person approaches it, what combination. And when you did the study of the combination, there was rationale to do the combination. At that time, the MDM2 was a toxic drug, and our CDK4/6 inhibitor, which we've had experience with, and Mark Dixon has done multiple series of studies on that drug. There are new generation CD4/6 that have less myelosuppression. And as you said, the MDM2 newer generation have less myelosuppression. We're looking at exploring the activities at SARC. We have a study using a new generation of abemaciclib instead of the first line palbociclib in the past, partly because there's some rationale that might be better. And then there are multiple MDM2s that are coming out and moving forward. So I think in our space, based on the work that Neeta did and others, is this still the right targeting that we should still explore, the MDM2 and the role of CDK4/6 in 24 and beyond? And just like your thoughts on that, both of you.
Absolutely. I don't think the MDM2 story or the CDK4 story is complete just yet. As you said, a lot of is in the target and a lot of is in the drug and how well it inhibits the target with less side effects, just as Dr. Razak said. So I think the newer generations hold hope. And I think as we're seeing more activity with these newer generation drugs with more tolerable toxicities, we can then start exploring what's really happening in those patients responding and those not responding, and then develop those rational combinations that might even further enhance the response that we see in this tumor type.
There was another target that a lot of us participated in trial. I know, Albie, you were quite heavily involved with the drug selinexor. And maybe you can share with our group here how that design was developed, the conduct of that trial, your experience with it, and kind of the result, and whether or not that is still another target or mechanism that we should approach in liposarcoma. Dr. Razak?
Yeah, thanks, Dr. Kuno. So, as you know, selinexor is a unique drug. The idea is not new, but it was very hard to execute this as a drug for a long time, because the whole premise is to get a drug that can block something that is called the nuclear export protein, right? And the whole idea is that you retain all the tumor suppressor proteins, and you can combat cancer that way. So we were lucky with this compound because we had our hands on it very early on. We actually did the first patient first visit in the phase 1 setting. And it was very clear. There were two things that were clear. The first is that it's got activity across several tumor types, but mainly in terms of disease stabilization, not necessarily a response. And the second thing is that the toxicity profile is not insignificant. Nausea, vomiting, GI toxicities, it was very clear, and as well as myelosuppression. But across several tumors, we see change of disease kinetics. Disease that are progressing and then they stop progressing, and some of them could be durable. And one of them was sarcomas. So there was because of that was a study that we did, and with the sarcoma program being involved, clearly there is some cross passages of patients, and that led to a early interrogation of sarcoma patients using a food effect cohort type study. So we were trying to kill two birds with one stone, if you like. And in that study, it was very clear there were several histologies of sarcoma that may benefit from this drug. But the ones that are most promising, looking at that limited data, was Dediff liposarcoma, which really became the impetus for the SEAL study, which is selinexor versus placebo, if you like, in pre-treated Dediff liposarcoma patients. So that was a study that accrued very quickly. Over 280 patients over a short period of time. The primary endpoint was PFS. Numerically, the PFS was met with a hazard ratio of about 0.7. But if you look at the exact numbers, if you look at median PFS, the improvement of PFS survival is only about 0.7 months. So it's actually very small. So I question whether, despite the study being reported as a positive study, right, where it stands in terms of where we treat liposarcoma patients, I think still remains a question. Toxicity still remains a challenge. If you look at the quality of life data from that study, there is some improvement in the pain score, but nothing else. So, it's not an easy treatment to administer. We have just completed a study using this compound in a number of sarcoma patients, not Dediff liposarcoma, but we are trying to modify the dosing. So we use split doses and we use metronomic doses. That study has just been completed. We have completed accrual, and is subject to a presentation in the very near future. But this I think with regards to selinexor, I think we need to really sit down and think whether it has a place in Dediff liposarcoma, but more importantly, if it does, how do we place it? Because the current schedule and dosing is, in my mind, not beneficial.
Yeah, when the SEAL study was published, it looked like it met its endpoint. When you look in the deeper dive, the magnitude of absolute benefit was small. And secondly, the toxicity. And we look forward to kind of seeing how your new study is a broader part. Dr. Somaiah, does your team typically incorporate selinexor in the regimen? I know it's approved for multiple myeloma and other exploring other hematologic, but it's generally not one that we take off the shelf right now to start using. Dr. Somaiah?
No, you're right. Not really. And I agree with everything Dr. Razak said. I think, just participating on the study, that some patients benefited. So it does have activity. But when you look at the whole group, the dosing, the side effects, and again, maybe they need better symptomatic management and a better dosing schema in order to be able to keep patients on it for longer at the right dose to see the true benefit. And I was hoping that we would see some correlative data from that study to see, if those responders, what really is going on different to take the drug further. But I don't use it currently in my standard treatments. Unless there's a trial available, I'll be happy to enroll again. But yeah.
Well, that then turns our attention, we do think targeting MDM2, the CDK4/6, based on preclinical work, still is a target. We just got to find newer generations and new ways of combining it. Maybe selinexor might be something with a newer way to do it for other sarcomas. But Neeta, Dr. Somaiah, you kind of published some data on the role of chemotherapy, systemic chemotherapy, specifically for retroperitoneal liposarcomas, but kind of what is the approach, and we'll get Dr. Razak's approach of, since we don't have a trial, what is the approach of cytotoxic chemotherapy in this space?
Yeah, and the impetus to do that retrospective review is, it's great to have kind of a benchmark, because I know there's data out there, very poor responses with chemotherapy, and a lot of patients never get chemo for this, but our experience had been a little different. So when we look, we published on 80 plus patients, just standard chemotherapy, and what we see is the responses, as published previously, are almost exclusively in Dediff liposarcoma with chemotherapy. The Well-diff liposarcomas, unless there is a focus of more sclerotic or more cellular areas, they do not derive benefit from the chemotherapy. Combination chemotherapy seemed to be the one that led to more responses. Mostly adriamycin-based therapy was used in frontline setting, neoadjuvant, or in the advanced stage. And then even Gemtax, we actually published on gemcitabine docetaxel also in terms of looking at the response. And as reported previously, the RECIST responses are around in the 20% range when we look at chemotherapy with these two main regimens. The adriamycin regimen for gemcitabine docetaxel is more like 10%, but the patients who benefit do seem to derive prolonged benefit. So I think, there are two nuances. One is, of course, the response rate, some benefiting and benefiting well, and the other is identifying those who are responding is not always, always clear by RECIST measurements. So when you look at the vascular responses on this, with chemotherapy, the response rate is more like 30%, and that's what we determined with our radiology collaborators. So that is not very different from what we see with other sarcoma subtypes where we use chemotherapy routinely. So currently, in the absence of a clinical trial, I would use, if the patients are eligible, I would use adriamycin-based regimens in the front line. If they are in the neoadjuvant setting, trying to then get to spare the kidney because they're very large, then I would use adriamycin ifosfamide combinations because they could still get it. And the goal is to shrink it to get them to surgery. We've also used gemdocetaxel with good outcomes in some patients. And again, we usually image after 2 cycles because, there are some patients who won't benefit. So we can identify that early and then proceed with patients who are benefiting. And then we do have, trabectedin, eribulin, that are approved in the space. And in some patients, we do derive benefit. But I'll put in a plug whenever possible. We have very good trials coming up for this space that we should always prioritize that. Yeah.
Absolutely, and it's important. Albie, how about the Canadian group? How do you guys approach, cytotoxic chemo?
Yeah, so very similar to what Dr. Somaiah says. I think on top of my mind, the real difference really is the approach in curable patients. In the neoadjuvant adjuvant setting, we are one of those practices where we don't really use adjuvant therapy. And neoadjuvant therapy is really being used for borderline operable cases where we really wanted to improve a better resection margin. or within part of a clinical trial. Obviously, STRAS-2 now is going on. In the metastatic setting, our approach is exactly the same. Doxorubicin combinations or single agent is our mainstay drug, followed by gemcitabine, taxotere. Eribulin and trabectedin is a bit patchy, the use, because it's about funding. So again, because our drugs are funded via the government, they have the order of which they allow access to the drugs is very high. So you really need to prove survival benefit. For example, older drugs like dox and gemtaxotere that gets passed through because they're no longer within that remit of looking at health economics and so forth. But even with eribulin, where there is a survival benefit, the health economics parameter is still not meeting what they would use for funding. So you can imagine, for us, we are dependent on an access program for eribulin at the moment, and unless a patient has got private insurance, we cannot get trabectedin because that program has closed in Canada. So again, we have that problem. That's why we accrue heavily in clinical trials, because it's truly a source of treatment option. One of the drugs we still use is DTIC. Would you believe it? Some people wouldn't consider it, but we still have got some people who benefit from it. Like Dr. Somaiah says, a lot of these treatments are available, but how you match them to patients are going to be our biggest challenge, right? Because some people, they have got good disease biology and they benefit from it, and some people, regardless what they do, they don't do well. And your classical RECIST measurement is not a good tool to predict who benefits from drug versus not.
And I might add, we're very similar in that we also do not, for this subtype, would not give adjuvant therapy. It would only be neoadjuvant, and then, of course, pretty similar.
Well, you highlighted a couple points here. Number one is selecting the right patients, and clearly a clinical trial. And Dr. Razak, you did discuss the STRAS trial 2, which is surgery plus or minus neoadjuvant chemo. And I think we in the United States have an opportunity, so everybody should get to a center that would do that. This is also done in Europe, so this is a combined effort. The other part that you both brought up is when you're given these drug therapies, you have to understand the goals. And I know, Neeta, you kind of said vascular enhancement. Well, you're really talking CHOI criteria just to kind of see the response, and I know. But this is why you have to think too, is that you need to get to centers that understand the drugs, the biology of the drugs, what are the goals you're going to use, and how to interpret those scans. So I do think that's why we in the sarcoma realm study our own images, look at our own images with the help of radiology accordingly, and then help migrate and manage, expectation to say, stay on therapy, it's working, it's not shrinking, but look at that enhancement, as long as you're doing okay. And I think, again, going back to the beginning, expertise, volume will speak a lot for this space. So, we're still using drugs that we've talked about, doxorubicin-based therapy, gemdosi. I know, Anita, you've kind of published in that space, trabectedin, eribulin. But Albie, you brought out dacarbazine. You threw out DTIC. So it's interesting. Yep, and when we're done, dacarbazine is still an agent that, can be done, and it's been an old drug, but that's still something that can be used for these patients. We've covered a lot of ground on where we are with the cancer centers. We've covered a lot of ground on where we are today with, the molecular little bit of this space and drug combinations. You both have spent time thinking about where we need to be. We'll give some time for each of you to say where do you think we should be doing in 2024 and beyond? So we'll start with Dr. Somaiah in this space in liposarcoma.
So 2024 and beyond, I think there are a couple of areas, some that we discussed. I think what's the lowest hanging fruit is, completing the MDM2 inhibition story and how best to bring that to patients. Then we'll be exploring combinations after, similarly with the CDK4 inhibitors. I still have a lot of interest in immunotherapy, which again, albeit for Dediff, liposarcoma is not very active, and so I would not use it outside of a clinical trial. But there are combinations that we use in some patients who seem to derive significant benefits. So I think we really have to start looking closer at factors that we can identify on pathology that will help select these patients. So more work's happening in that area. I think, as we just alluded to, just understanding as we design trials for this space, we have to be really cognizant of how we're selecting the patients, because there's so much variability and heterogeneity. Because we don't want to lose a drug that is active just because of a badly designed study. That happens quite often. And coming together as a group to say, okay, we need to really put an effort into the radiology imaging characteristics as well that we look at, and how we select our endpoints for these studies. So I think the MDM2 CDK4 story, yes, and I do hope that as we dig deeper into what's happening, because I think an unmet need, which we didn't really talk about, is the well-diff liposarcomas, and very frustrating sometimes to take care of patients who are progressing with limited options. And I think more to come on that as we look at molecularly targeted agents, and also looking at, as I said, other epigenetic changes. And as these epigenetic drugs come into the market, we will be able to. And there are also some drugs that can target these the circular DNA in tumors, in tumor cells. So I think more to come on that in the future, but I'll stop there.
Wow, we got a lot of work to do, but it sounds like we have a trajectory. Dr. Razak?
Yeah, I agree. I think the reality is that the MDM2 and CDK4 story needs to be explored till the end, if you like. We are nowhere near close to that. Apart from combination, positioning the drug will be important as well. So say if Bright Line 1 is not a study that is positive, the question is, can it be used as a maintenance agent? Because we know that these drugs have got activities, just how to deploy it in a meaningful and safe manner. The other thing as well is that the use of MDM2 as something that creates synergy with radiation has been attempted before, but as I understand it, that study has ended prematurely because of challenges with COVID and recruitment and whatnot. And I think, again, if Bright Line 1 is a positive study, I think then we have a compound that can be viable for that part of interrogation, because we haven't looked into the earlier parts of managing Dediff liposarcoma that way. Agree, immunotherapy should be pursued as a treatment option. Obviously, within a study, there's an NCI study, as you guys know, that looks at ipilimumab, nivolumab, and cabozantinib that's going on. And last but not least, there's a plethora of new agents, but we really need to understand the scientific rationale into these studies, because to get the attention of whoever owns those molecules, sarcoma being a relatively rare disease compared to other disease types, always remains a challenge.
So it sounds like we had work to do on the preclinical part. We got work to design trials, and we need to work on trials, the Bright Line you talk about using their MDM2, that there's some additional studies that could be built around the MDM2, because you, as Neeta said, you got to answer the right question, and then you don't want to throw a drug away because you asked the wrong question or used it in the wrong scenario. What I'm hearing from us is Megan and I are going to have another podcast to talk about immunotherapy. We didn't get to your study, the durvalumab and tremelimumab for that, Neeta, you published, and I didn't see a lot of activity, but what you're saying in DDIF, but you have to say is we might have selected the wrong patients. And how do you select the right patients who would benefit? And that's a lot of work that we're trying to do at SARC and other groups as well. So that'll be another topic we'll bring back. So thank you both for sharing your expertise with us today on liposarcoma. We look forward to hearing and reading a lot about the work that you're continuing to do and share your research in this field. Are there any additional comments to our audience that you might have?
Well, I really enjoyed this podcast. It helps jog the brain again about directions that we need to take. So no additional comments, but I would say more to come in this space, because there are a lot more great investigators working in this space, and a lot more trials that the patients will have access to. So it's an exciting time.
Definitely. Dr. Razak?
More or less the same, but at the end of the day, I think for this disease space, we haven't had the breakthrough that the patients deserve, but progress is being made, a lot even if you look in the last 10 years. So hopefully we'll get a breakthrough soon that we can all pass to our patients with delight.
We love practice-changing research and practice-changing studies, and that's why we do this every single day. So again, thank you both for your time. Thank you for our audience for listening, and we look forward to a future podcast. Thank you all.
Thank you for listening. Be sure to subscribe so you never miss an episode of SARC Talk. To find out more about SARC, please visit our website at sarctrials.org. To suggest a topic or for questions, please email us at sarctalk@sarctrials.org. The SARC Talk series is made possible due to funding from Boehringer Ingelheim. Together, we can find a cure for all forms of sarcoma.